Here we're going to talk about central nervous system disorders, chapter 18. Our objectives for today are to explain the physiological process of nervous system reorganization following injury, define and discuss the common disease processes and clinical presentation of the central nervous system, and discuss the indications and support physical therapy interventions for the central nervous system. First, let's review upper motor neurons and lower motor neurons. Upper motor neurons are located in the brain and spinal cord, transmitting signals to lower motor neurons. Lower motor neurons are located in the spinal cord and brainstem, directly connecting to muscles for contractions. Skeletal or striated muscle contraction is initiated by lower motor neurons in the spinal cord and brainstem. The cell bodies of the lower motor neurons are located in the ventral horn of the spinal cord, gray matter, and in the motor nuclei of the cranial nerves in the brainstem. Mechanisms of cell death include necrosis, which is cell death caused by necrosis involves cellular swelling and disintegration. Inflammatory cells surround necrotic debris, leading to the formation of cytotoxic compounds inside cells. Damaged cells release exocytotoxins that can further damage surrounding cells. Apoptosis is programmed cell death. It is an organized process of cell death involving cell fragmentation and degradation without an inflammatory response. Dysregulation of apoptosis can contribute to neurodegenerative disorders. Dysfunction within the nervous system can affect both neurons and glial cells. Glial cells provide nutrition, protection, and form myelin around nerve cells. Stem cells play a role in creating new glial cells and neurons for repair and maintenance. Neuronal cell death is a hallmark of many neurologic disorders. The intensity of cellular injury determines whether cells undergo necrosis or apoptosis, impacting overall tissue and organ function. Understanding these mechanisms is crucial for studying and treating neurologic diseases, where preservation of neuronal and glial cell function is essential for maintaining proper nervous system function. All communication between nerve cells or neurons occur via neurotransmitters. Neurotransmitters are chemical messengers released by neurons that transmit signals to other neurons or target cells, such as muscles or glands. Electrical signals or action potentials travel along the neuron's axon to the next neuron. This transmission occurs through a series of biochemical events involving neurotransmitter release and receptor activation on the postsynaptic neuron. The specific location of neurons within the nervous system influences their function and connectivity. Neurons receive input from other neurons, input cells, and transmit signals to target cells such as other neurons, muscles, or glands. The size and shape of neurons, which is called cell morphology, contribute to their function. Neurons can vary in size and shape based on their specific role and within the nervous system. So example, sensory neurons, motor neurons, or interneurons. Understanding these factors is essential for studying neural communication and the functioning of the nervous system. Differences in neuronal structure and connectivity contribute to the complexity of neural networks and their role in various physiologic processes and behaviors. A synapse is a junction between two neurons where neurotransmitter molecules are released from the presynaptic neuron's axon terminal and bind to receptors on the postsynaptic neuron. Neurotransmitters are stored in vesicles within the presynaptic neuron terminal. When the presynaptic neuron is depolarized or activated, it releases neurotransmitters into the synaptic cleft. the space between the neurons. Release neurotransmitters bind to specific receptors in the postsynaptic neuron membrane. This binding triggers a response in the postsynaptic neuron, either excitatory or inhibitory, depending on the neurotransmitter and receptor type. Neuronal firing rate is the frequency of action potentials or nerve impulses in the presynaptic neuron, which influences neurotransmitter release. The quantity of neurotransmitter available for release affects the strength of synaptic transmission. The balance between excitatory and inhibitory neurotransmitters modulates neural activity. Neurotransmission is the process in which neurons communicate with each other. It involves the release, diffusion, and binding of neurotransmitters across synapses. Neurotransmitters play a fundamental role in regulating nervous system function, including sensory perception, motor control, cognition, and behavior. Understanding these mechanisms of neurotransmission and synaptic communication are crucial for unraveling the complexity of neural networks and their role in brain function and behavior. The afferent pathway carries sensory information from sensory receptors located in the periphery of the body to the central nervous system, which includes the brain and spinal cord. Stimuli from the external environment or internal body are detected by sensory receptors, example touch, pain, or temperature. Sensory information is transmitted via afferent neurons or sensory neurons to the central nervous system. This pathway allows us to perceive and interpret sensory stimuli such as touch, temperature, pain, and proprioception, which is the body's position in space. The efferent pathway carries motor signals from the central nervous system to peripheral tissues, including muscles and glands. Signals originate in the central nervous system, the brain or spinal cord, and are transmitted via efferent neurons or motor neurons. Efferent pathways control voluntary and involuntary movements or motor functions and regulate glandular secretions. An example is when you decide to move your hand to pick up a cup of coffee. The brain sends motor signals through efferent nerves to the muscles, causing them to contract and execute the movement. Damage or lesions along these pathways can lead to sensory disturbances, such as paresthesia or motor deficits. Specific patterns of symptoms, whether it be ipsilateral or contralateral, for example, can help localize lesions within the nervous system. For example, a lesion in the spinal cord may lead to ipsilateral sensory deficits, whereas a lesion above the medulla can result in contralateral symptoms. Understanding the afferent and efferent pathways is essential for diagnosing and managing neurologic disorders that affect sensory perception, motor function, and overall nervous system communication. Proprioception is the sense that allows us to perceive and be aware of the position, movement, and orientation of our body parts in relation to each other and the environment. Proprioceptive information comes from sensory receptors located in muscles, tendons, joints, and the inner ear, which is the vestibular system. Proprioception enables us to maintain body posture and balance, coordinate movements, and perform motor tasks with precision. It helps in adjusting muscle tone and tension based on the body's position and movement. The sensory feedback allows us to navigate our surroundings and perform tasks without relying solely on visual or auditory cues. Conditions or injuries that affect proprioceptive pathways can lead to difficulty in maintaining body position, decreased postural control, and impaired coordination. Ataxia is disturbances in proprioception can result in ataxic movements characterized by uncoordinated or clumsy motions. Proprioceptive training and exercises are important components of rehabilitation programs to restore or enhance proprioceptive function in individuals with neurologic or musculoskeletal disorders. Understanding proprioception is crucial for maintaining balance, coordination, and motor skills it plays a role in daily activities and movement control. The parietal and premotor areas of the cerebral cortex play crucial roles in identifying targets in space, determining actions, and creating motor programs. The brainstem and spinal cord are responsible for executing motor tasks initiated by the cerebral cortex. The cerebellum and basal ganglia interact to establish motor plans, coordinate movements, and regulate posture and balance. Damage or lesions at any level in the central nervous system can result in abnormal movement patterns. Again, ataxic movements are characterized by the loss of voluntary muscle coordination and are often associated with cerebellar dysfunction. Individuals with ataxia often exhibit an unsteady or staggering gait, with feet placed wider apart to maintain balance. Dysmetria is the inability to accurately judge distances, leading to overshooting or undershooting of targets. Intention tremors are tremors that occur during voluntary movements, worsening as the limb approaches its target. Ataxia is diagnosed based on clinical examination, including assessment of gait, coordination, and motor function. Treatment of ataxia focuses on addressing the underlying cause, such as cerebellar dysfunction or neurologic disorders. Rehabilitation strategies may include physical therapy, occupational therapy, and adaptive devices to improve mobility and function. Movement coordination involves cooperation from multiple brain structures across the central nervous system. Abnormal movement patterns in neurologic disorders can arise from lesions anywhere in the central nervous system, with resulting movement disorders related to location and severity of damage. The cerebellum plays a crucial role in motor learning, particularly during acquisition phase of learning new activities. Again, dysmetria refers to errors in force production during movements leading to overshooting or undershooting targets. Scanning speech is characterized by non-melodic and slow pronunciation of words, often associated with cerebellar dysfunction. Dysdiadokinesia is an impaired ability to perform rapid alternating movements such as tapping or pronating and supinating the forearms. This condition is commonly linked to cerebellar dysfunction and can result in clumsiness and lack of coordination. Dysdiadokinesia can be caused by various conditions affecting the cerebellum, including cerebellar degeneration, stroke, multiple sclerosis, tumors, and certain genetic disorders. Dysdiadokinesia symptoms include clumsiness and incoordination during rapid alternating movements, lack of smoothness and precision in executing rapid movements. Gaze-evoked nystagmus refers to involuntary rhythmic oscillations of the eyes that occur when attempting to fixate on lateral targets. It results from cerebellar dysfunction, which impairs the ability to hold the gaze steady on an object. When looking at a lateral target, the eyes drift back towards midline and then rapidly return to the target, causing a flickering or oscillatory movement. Lesions affecting the brainstem or midline cerebellar structures can lead to gaze-evoked nystagmus. Ocular dysmetria involves inability to accurately focus the eyes on a target, resulting in under or overshooting a target. This condition is often associated with cerebellar dysfunction, which plays a role in coordinating eye movements. Saccadic movements rapid eye movements that shift the gaze from one target to another. Smooth pursuit is controlled eye movements used to track and follow a moving target. Understanding these concepts is essential for diagnosing and localizing neurologic lesions affecting eye movement coordination. Cerebellar dysfunction, in particular, can manifest as various eye movement abnormalities, including gaze-evoked nystagmus or ocular dysmetria. Diagnosis and management of these conditions often require a comprehensive neurologic assessment and may involve rehabilitation strategies targeting motor control and coordination. Some various gait disturbances include a wide base of support, which refers to a stance where the feet are spaced further apart than normal, which can provide greater stability. Staggering gait involves an unsteady or irregular walking pattern characterized by lack of smoothness and coordination of movements. Normal arm swing during walking involves reciprocal movement of arms opposite of the legs, aiding in balance and coordination. So atypical arm swing is another gait disturbance. Atypical arm swing, such as reduced or asymmetrical arm movement, can indicate disturbances in motor control or neurologic dysfunction affecting coordination. Stance and swing phases refer to specific periods of the gait cycle where stance involves weight bearing on one leg, while swing involves swinging the other leg forward. Irregularities in stance and swing phases suggest difficulty in timing and coordination of muscle activation during walking. Heel-to-toe walking or tandem gait requires walking in a straight line, placing the heel of one foot directly in front of the toes of the other. Difficulty with this task may indicate impairments in balance, proprioception, or motor coordination. Normally, individuals can adapt their gait to changes in terrain, example, uneven surfaces or slopes. Loss of adaptation suggests reduced proprioceptive input or impaired motor control when encountering environmental challenges. Lateral oscillatory base refers to side-to-side swaying or instability during stance phase of gait. This may be caused by impaired balance coordination, vestibular dysfunction, or proprioceptive deficits. Apathy is often associated with dysfunction in the frontal lobes, particularly the dorsolateral prefrontal cortex. This region is involved in motivation, goal-directed behavior, and emotional initiative, reduced emotional responsiveness, and general lack of interest or concern about one's circumstances. The case of Phineas Gage, a railroad worker who survived an accident and resulted in frontal lobe damage, demonstrated profound changes in personality and behavior. Left frontal lobe lesions can affect problem-solving abilities, memory, initiation of activities, judgment, impulse control, and social behavior. Individuals may exhibit poor decision-making, impulsivity, and alterations in personality traits. Damage to the frontal lobes, especially the orbitofrontal cortex and dorsolateral prefrontal cortex, can lead to various behavior changes. These include slow information processing, impaired judgment, uncontrolled or disinhibited behavior, irritability, and emotional lability. Dysfunction in the right hemisphere can result in deficits related to spatial orientation and motor responses in external space. Individuals may struggle with spatial awareness, navigation, and generating appropriate motor actions in response to visual or environmental cues. This syndrome can affect activities such as dressing, navigating through space, and performing tasks that require coordination and spatial reasoning. These symptoms highlight the critical role of specific brain regions in regulating behavior, cognition, and emotional responses. Dysfunction in these areas can significantly impact an individual's daily functioning and quality of life, emphasizing the importance of neurorehabilitation and targeted interventions to address these deficits. Dysarthria refers to motor speech disorder characterized by difficulty in articulating words due to weakness, paralysis, or incoordination of the muscles involved in speech production. This can result in slurred speech, imprecise articulation, and difficulty controlling the rate and rhythm of speech. Dysarthria can arise from damage to the motor cortex, cranial nerves, and other motor pathways involved in speech production. Anarthria refers to the inability to produce speech due to paralysis, weakness, or other motor impairments affecting the speech muscles. Individuals with anarthria may be unable to form recognizable words or sounds due to severe motor deficits and speech musculature. This condition typically results from extensive damage to the motor areas involved in speech production. Expressive aphasia, or Broca's aphasia, is a type of language disorder characterized by difficulty in speech production or language output. It is associated with damage to the left frontal lobe, particularly in Broca's area, which is responsible for language expression. Individuals with expressive aphasia may struggle to form coherent sentences, speak in fragmented or garbled phrases, or have difficulty finding the right words to express their thoughts. The localization of speech centers, including Broca's area within the left frontal lobe and temporal lobe, highlights the specialized organization of language processing in the brain. Damage to these specific brain regions can result in distinct speech and language deficits, underscoring the importance of neuroanatomy, localization, and understanding and diagnosing communication disorders. Alexia refers to the inability to read due to brain injury or disease. It can occur even if the ability to write and understand spoken language remains intact. Agraphia refers to difficulty in writing, characterized by abnormal or clumsy handwriting, spelling errors, and impaired ability to compose written language. It can occur independently or alongside other language impairments. Apraxia is an acquired disorder characterized by loss of skilled, purposeful movement despite intact sensory and motor functions. There are different types of apraxia. Ideomotor apraxia, which is the inability to perform motor actions or gestures on command, even though the individual understands the action. And ideational apraxia, which is difficulty in carrying out sequence or coordinated movements, where each component of the action can be performed individually. Agnosia refers to inability to recognize or identify objects, people, or sounds, despite normal sensory function. It can affect different modalities such as visual agnosia, auditory agnosia, or tactile agnosia. Ataxia is a neurological condition caused by dysfunction in the cerebellum, leading to impaired coordination, balance, and voluntary movements. It results in a lack of smooth and precise muscle control. Receptive aphasia, or Wernicke's aphasia, affects the language comprehension. Individuals with this type of aphasia may produce fluent but non-succinctual speech and have difficulty understanding spoken or written language. Altered level of consciousness. Altered consciousness can be caused by various factors, including loss of blood flow, ischemia, hemorrhage, anesthetic toxicity, hypoglycemia, which is low blood sugar, hypothermia, or status epilepticus, prolonged seizure activity. These conditions disrupt normal brain function, leading to changes in arousal and responsiveness. Hyperarousal is manifested by restlessness, agitation, or delirium. Hyperarousal reflects an exaggerated state of alertness or reactivity. Hypoarousal ranges from drowsiness to stupor and coma. Hypoarousal signifies reduced wakefulness and responsiveness. Stupor is a state of unresponsiveness requiring vigorous stimulation to arouse. A coma is complete unarousable unresponsiveness, often associated with profound brain dysfunction. Persistent vegetative state is characterized by unresponsiveness due to severe brain damage affecting the brainstem. Patients may exhibit reflexive movements, but lack of conscious awareness or cognitive function. Locked-in syndrome results from damage to the pons, leading to paralysis of all voluntary muscles except for eye movements. Individuals with locked-in syndrome are fully conscious and aware but unable to move or communicate, aside from limited eye movements or blinking. Altered consciousness is not a standalone disorder, but rather a reflection of underlying neurologic dysfunction or injury. The cerebral cortex, brainstem, and thalamus play crucial roles in regulating arousal, wakefulness, and consciousness. Damage to specific brain regions can disrupt these functions, resulting in various states of altered consciousness. Memory problems. The hippocampus is critical for the formation of new memories and the consolidation of short-term memories into long-term memories. The thalamus and forebrain are also involved in memory processes, including recent memory and working memory. Types of memory include working memory, which involves the ability to temporarily hold and manipulate information needed for tasks such as remembering a phone number or following instructions. Declarative memory involves the retention of facts and events from personal experiences. This includes episodic memory, which is specific events, or semantic memory, which is general knowledge. Procedural memory involves the memory of how to perform specific tasks or skills, such as riding a bike or playing a musical instrument. Amnesia is a disorder of recent memory. Antegrade amnesia is characterized by inability to form new memories after the onset of amnesia. Individuals with antegrade amnesia have difficulty encoding new information into long memory. Retrograde amnesia involves the loss of memory for events that occurred before the onset of amnesia. Retrograde amnesia can vary in severity, with some individuals unable to recall recent events or a more extensive period of past memories. Traumatic amnesia refers to memory loss specifically related to a traumatic event or injury. It can result in the inability to recall certain aspects of the traumatic experience. Amnesia can have various causes, including brain injuries such as damage to the hippocampus or other memory-related structures, neurologic conditions, or psychological factors. Understanding the different types of memory and amnesia is crucial for assessing and managing individuals with memory disorders and cognitive impairments. The autonomic nervous system controls unstriated or smooth muscles, cardiac muscles, and glandular tissues throughout the body. It consists of efferent pathways, including sympathetic and parasympathetic nervous systems, which regulate involuntary functions such as heart rate, blood pressure, digestion, and glandular secretion. Autonomic neurons are located at multiple levels from the cerebral cortex to the spinal cord, with critical control centers in the hypothalamus and brainstem. The hypothalamus is a key region in the brain responsible for integrating autonomic and endocrine responses critical for maintaining homeostasis. Functions of the hypothalamus include regulation of body temperature, initiating responses like sweating or shivering to maintain a stable temperature, control of hunger and thirst by monitoring nutrient levels and blood glucose to regulate appetite and thirst, regulation of fluid balance, sensing changes in blood osmolality, and initiating thirst responses, sleep and circadian rhythms, controlling the sleep-wake cycle and synchronizing biologic processes with day-night cycles, hormone release, producing, releasing, and inhibiting hormones that influence the pituitary gland secretion of various hormones, autonomic nervous system control, integrating signals that regulate involuntary functions like heart rate and digestion, and emotional responses, playing a role in emotional expression and associated physiologic responses. The hypothalamus acts as a crucial coordinator of bodily functions, receiving input from various sensors and integrating signals to maintain internal stability and respond appropriately to changing conditions. Its role extends to regulating basic physiological processes and influencing emotional and behavioral responses. Visceral afferents from internal organs are carried by the vagus and glossopharyngeal nerves. These nerves play essential roles in functions like swallowing, vomiting, and coughing, which are vital for maintaining airway protection and digestive responses. Traumatic spinal cord injury, particularly injuries above the T5 level, can lead to severe and disabling dysfunction of the cardiovascular, gastrointestinal, bladder, and sexual systems. Common autonomic dysfunctions include both supine and orthostatic hypotension, as well as risks of bradycardia and cardiac arrest during certain activities that activate vasovagal reflexes. The vagus nerve, cranial nerve 10, is part of the parasympathetic nervous system, responsible for slowing the heart rate and promoting the state of calm after stress. Activation of the vagus nerve during the vasovagal reflex can lead to sudden drop in heart rate and blood pressure, causing temporary loss of consciousness. Triggers for the vasovagal reflex include emotional stress, fear, pain, prolonged standing, or sudden changes in body position, which can activate autonomic responses affecting heart rate and blood pressure. Understanding the complexities of the nervous system, including brain structure and function, is essential for comprehending how pathology and injury impact body functions. Pure autonomic nervous system failure without other neurological deficits is uncommon, highlighting the integrated nature of the neural regulation in the body. Aging and the central nervous system. With aging, there's a reduction in the adult brain weight due to loss of neurons and shrinkage of existing cells. Diminished blood supply to the brain can contribute to reduced cellular function and structural changes. Plaque formation refers to the accumulation of abnormal protein deposits in the brain, which is closely associated with conditions like Alzheimer's disease and dementia. These plaques can interfere with normal brain function and contribute to cognitive decline. Aging is accompanied by neurochemical changes, including a decrease in neurotransmitter synthesis and the reduction in key neurotransmitters like dopamine, norepinephrine, and acetylcholine. These changes can lead to alterations in emotional regulation, attention, and overall cognitive function. There is selective atrophy or shrinkage of specific brain regions in the aging central nervous system. Loss of cells and nerve conduction slowing can affect both motor and sensory functions, contributing to age-related decline in coordination and responsiveness. As individuals age, increased exposure to environmental contaminants and the cumulative effects of past trauma can lead to abnormal replication of DNA and further damage to brain cells. This heightened vulnerability contributes to the progression in neurodegenerative conditions and age-related cognitive decline. Aging often involves a decrease in brain weight due to atrophy of brain tissue, including a reduction in the number and size of nerve cells. This atrophy can lead to a decline in nerve conduction velocity, affecting the speed at which nerve signals are transmitted. Neurofibrillary tangles and abnormal neurological fibers, along with plaques, are characteristic features associated with neurodegenerative diseases like Alzheimer's disease. These structures can impair neuronal function and contribute to cognitive decline. Aging is associated with alterations in neurotransmitter activity, synthesis, and receptor function. Changes in neurotransmitter levels and receptor sensitivity can impact cognitive function, mood regulation, and other aspects of brain function. Aging can lead to a loss of vestibular function, affecting balance and contributing to symptoms like dizziness. Decreased sensory input related to balance and mobility can increase the risk of falls and impact overall mobility. Aging is often accompanied by delayed reaction times, which can affect motor coordination and response to stimuli. Visual changes, including decreased acuity, peripheral field loss, and impaired depth perception, are common with aging and can impact activities of daily living and safety. Other individuals are at a higher risk of various neurological conditions, including strokes, subdural hematomas, and brain tumors. Vigilance for any changes in or unusual behaviors is important to promptly identify and address potential neurological issues. Neuroplasticity refers to the brain's ability to recognize itself by forming new neural connections in response to learning, experience, or injury. It involves changes at the cellular and structural levels within the brain. At the cellular level, neuroplasticity involves synaptic plasticity, or changing the strength of connections between neurons, and neurogenesis, which is the formation of new neurons. At the macroscopic level, neuroplasticity can lead to reorganization of brain regions and changes in functional connectivity between different areas of the brain. Learning new skills, exposure to stimulating environments, physical exercise, emotional experiences, and brain injury can all influence neuroplasticity. Activities that change the brain and require repetition, such as practice, are particularly effective in promoting neuroplastic changes. Neuroplasticity plays a critical role in rehabilitation and recovery after brain injury or neurologic conditions. Early introduction of stimulating activities and rehabilitation interventions can promote neuroplasticity and optimize functional recovery. Neuroplasticity can lead to increased dendritic branching, synapse formation, glial cell activity, and changes in cortical thickness and brain weight. These structural changes support improved neural communication and functional adaptation in response to environmental demands. The concept of use it or lose it highlights the importance of ongoing cognitive and physical engagement to maintain and enhance brain function throughout life. Continual stimulation and activity help preserve and strengthen neural connections, while lack of use may lead to disuse atrophy.
I have half a brain. When people meet me, they have no idea. I only remember my very first seizure. I was at my daycare playing, and the next thing I knew, I was in an ambulance.
We hightailed it to the hospital and just watched her. She had another seizure the next morning, but nothing that they did worked. She was constantly falling to the left, and it got so bad that one of us had to be on her left side all the time.
It was to the point where I was having seizures every 3 minutes, and that wasn't cool.
The doctor explained that the only way they could treat it was to take out the half of the brain that was affected.
In very, very early childhood, the brain is thought to be in one of its most plastic states. And if you change the brain at that point, there may be a better capacity for the brain to reorganize.
I am a very positive person. A lot of times I'll joke that they took out the mean side of my brain and they only left the happy side.
If you had asked me 25 years ago if it was possible to take out half the brain and still have functioning life, I would have said, you've got to be crazy. But here we are.
Life now with half a brain is, for me, is no different than anybody else. I've been married 4 years. I live on my own with my husband. I'm really glad my parents did what they did, because I wouldn't be where I am now if I had had the surgery any later or had waited any longer.
It is essential to recognize impairments that contribute to abnormal motor control in patients with neurological deficits. This understanding helps tailor therapeutic interventions to address specific deficits. Motor learning involves patients with neurological deficits determining the optimal strategies for movements to perform motor tasks. This process requires practice and therapeutic interventions to facilitate learning and adaptation. Therapeutic interventions should be designed to help patients with neurological deficits learn appropriate movement strategies. Tasks may need to be broken down into components to focus on specific impairments and skills. For patients with neurological deficits, especially those with stroke or brain injury affecting certain areas of the brain, it is important that early treatment is crucial for maximizing effectiveness and promoting recovery. The interaction between the patient and the physical therapist assistant is critical for optimal motor learning to occur. A supportive and engaging therapeutic relationship enhances the learning process and facilitates progress. PTAs work towards attaining the highest level of function in patients with neurological deficits through goal-directed activities. These activities should be specific, relevant, engaging, and progressively challenging to promote meaningful improvements in motor skills and function. By emphasizing these principles of motor learning and rehabilitation, PTAs can play a vital role in helping patients with neurologic deficits achieve functional goals and enhance their quality of life. The tailored approach to motor learning and interventions is essential for optimizing outcomes and promoting recovery in this population.